First of all, I would like to thank the invitation. And today I'm going to talk about the infection control practice during the pandemic and also AMS during the pandemic. Here is a figure that shows the transmission mechanism of SARS-CoV-2 during the pandemic. And the infection is mainly transmitted through direct inhalation of the respiratory droplet from the infected patients. And also another route is through the fomite transmission. That means that the infection spread through the environmental contamination. And when a person contact the contamination and then touch the mucosa, the virus can spread into another person. This is what we call fomite transmission. And here is a figure that shows the transmission dynamics of SARS-CoV-2. Clearly, once we face an epidemic in the community, an immediate response is needed to stop the transmission of the virus. For example, in the community setting, which the social distancing and the use of many non-pharmaceutical interventions are necessary. And also during the early phase of the epidemic, to protect the transmission of the virus in the school, many procedures for students and teachers in the school setting are also necessary. And to prevent household transmission of the virus among the family members, it's also very important to have guidelines for the family members to stop the transmission in the household. And if not well prepared, or if we don't respond immediately, the virus can knock down thousands of healthcare workers out of function. And this has been observed in early phase of the pandemic in Europe and also in the States. And this figure shows that once a pandemic and an epidemic in the community occurred, without immediate response or without protective measures, the healthcare system will be knocked down by the transmission of the virus from the community to the hospital, and then the virus can spread in the hospital setting. But with immediate response and adequate protective measures, the transmission of the virus in the hospital setting can be mitigated to a lower level. In that case, healthcare system capacity can be sustained, and healthcare system can still provide service to many other patients who need healthcare, but without COVID-19. So I'm coming to the most important measures in the infection control for the containment of the virus spread during the community epidemic. I think it's the most important thing is to implement the so-called enhanced traffic control bundle, ETCB, based on patient risk stratification for your hospital. Firstly, you have to triage all the visitors and patients prior their entering into the hospital, and then separate these persons based on their risk stratification, and then separate these patient routes and also their disposition according to the risk to avoid cross-contamination. So it's very important during the community epidemic to protect the hospital. You have to triage all the visitors and patients at the entrance. You have to record the temperature for all visitors and patients. You have to get travel history for all the visitors and patients, and also to obtain TOCC information and respiratory symptoms for all visitors and patients when they before they enter the hospital. Also, such triage should be performed at ER and outpatient clinics. And based on the TOCC, temperature, and symptoms information, you can stratify patients into those with mild symptoms and then direct them to a remote epidemic clinic for further examination. And for those with fever or severe symptoms, of course, they have to immediately checked at the ER for the SARS-CoV-2 PCR or antigen detection. Once positive, of course, they have to be admitted in the quarantine wards for specific treatment. And so, again, based on the risk of COVID-19, visitors and patients' routes in the hospital can be divided into very clearly separate but one way and in one way. So for those with confirmed cases, confirmed COVID-19, they will be admitted to the isolation wards for further treatment. This is what we call a red zone area. And for those with suspected patients with initial negative testing, they can be admitted into the yellow zone. This in that specific region, they will be closely monitor for the progression of the symptoms. Once retested positive, they still have to be moved into the red zone for treatment. For all the rest of the patient with negative testing and also at very low risk for the infection, they will be transferred to the so-called green zone, the general ward, for the treatment of their disease. So in terms of preventing outbreak of COVID-19 in the hospital setting, first, you have to provide sufficient PPE to all the healthcare workers. And you have to screen all the admitted patients during the high peak of the epidemic before they enter the hospital. And for all the inpatients, close monitoring their symptoms and evaluation for inpatient pneumonia are also necessary, because once they may be tested negative at the triage, but once admitted, the symptoms may show the progression, and then in that case you have to retest the patient. And oftentimes, especially during the high peak of the epidemic, the retesting may become positive. So you have to do close monitoring for all the patients admitted. Also in the hospital, at every checkpoint, hand hygiene facility should be provided. And of course, hand disinfection is required at every checkpoint. And always, you have to tell all the patients and visitors and also healthcare workers for social distancing, and also mask wearing. And for the clinical teams, you have to subdivide them into different teams, serving different area, different group of the patient, just to avoid cross-contamination during the high epidemic. And also we have to provide education to all the healthcare workers for the infection control knowledge about the COVID-19, and also for healthcare workers, health surveillance is very, very important. Once any healthcare worker showed any symptoms, they should be tested immediately for COVID-19. And for all confirmed patients or healthcare workers, contact tracing and quarantine is necessary. And in this way, you can provide the further spread of the virus in the hospital setting. And this table shows the guidelines for the PPE use for the healthcare workers, and the hospital should provide sufficient PPE for all the healthcare workers working in the hospital during the COVID-19 pandemic. And this figure shows to you the deployment of alcohol dispensers at every checkpoint in the hospital. So in that case, the possibility of fomite transmission can be stopped. Now moving to the antimicrobial resistance. Antimicrobial resistance has been a slow-growing disaster that occurred even before the pandemic. So it's called AMR, it's called a silent pandemic during the pandemic. In the resource-limited countries, the limited availability of diagnostic tools for COVID-19 and weak preparedness to respond to the outbreak could further worsen the situation of AMR. This is a figure from a study in India that clearly shows that with the increase of the COVID-19 cases in the community, the consumption of doxycycline and azithromycin actually increased in parallel. So again, this is what I call AMR is a silent pandemic during the COVID-19 pandemic. And this is another study from the United States that showed that the spread of MDR-GMB infection in a COVID-19 patient care unit in a hospital. And as you can see from this figure, during the high peak of the COVID-19 epidemic, the cases with MDR-GMB infection in the COVID-19 care unit actually has been increased over time. And they analyzed the driving factors for this increase and confirmed that the increase may be due to the severity of these patients admitted into the unit and the higher antibiotic use for these patients, the double occupancy of single rooms by these patients, the policy, and also the modified infection control practices for the COVID-19 patients in this hospital. So they sought to solve this problem by many measures, and what they took to control the spread of the MDR-GMB are these solutions. First, they started the surveillance system for the surveillance culturing for all the inpatients in the COVID-19 wards. And secondly, they reinforced the infection control procedures for all the patients in the COVID-19 unit. And finally, they changed the policy of double room occupancy of COVID-19 in single rooms. With these measures, they successfully control the spread of the MDR-GMB in COVID-19 patients in the COVID-19 care unit in this hospital. So I think what do we do during the COVID-19 pandemic with AMR to control the AMR? I think one method that we can do is to make the best use of the digital device in our AMS system. You know, during the COVID-19 pandemic, it's better not to contact people as much as possible. So make the best use of the digital devices in your AMR system. Could provide a better could provide good improvement in your AMR for the containment of the spread of the MDR bacteria. So this figure shows to you the EMR system, actually EMR system and also digital documentation system actually is the backbone of a digital hospital digital transformation program. So, you know, in Chang'e Memorial Hospital, we have implemented the EMR system in our healthcare system early in early 2020s, and also in this system we deployed a hospital-wide computerized antimicrobial approval system in this 3,000-bed hospital to guide antibiotic use for all inpatients. And here is the IT infrastructure of our EMR system. We have the most important hospital informatics system, HIS system, for all the electronic chart records. We have a laboratory informatics system for all the laboratory testing results. And we also have PACS system, which is an integrated image system for all different kinds of images. So our AMR system actually is constructed based on these EMR system. And we basically put all these different elements of the EMR together with the antibiotic approval system. So our antibiotic review system actually is an intervention, one of the intervention that guide, you know, that apply the so-called prospective audit and feedback strategy according to the IDSA guideline for AMR for hospital patients. This is kind of front-end approach system. Here is the flow chart that shows how we work in this computerized antimicrobial approval system. Again, as I said, this is a front-end approach system applying the prospective audit and feedback strategy. All the prescriptions for the use of advanced antimicrobial agent will be transmitted through the EMR to the computer of the ID physician, and each ID physician in our hospital has to take care of 300 beds area for the inpatients, and the ID physician must review all the these antibiotic prescription within 48 hours after the prescription. And then they may approve the prescription after the review all the related clinical information of the patients. And they may of course disapprove the antibiotic choice. But in that case, they have to send back their feedback to the prescriber. And the prescriber may modify the regimen according to the suggestion from the reviewers. And sometimes the ID reviewer may submit a recommendation for an on-site ID consultation. And in that case, ID physicians will have to go to the ward to see the patients in person and then give recommendations on the management of the infectious disease of the patient. After we have executed this system for many years, and after 2010, we further modify the system by providing a second time review opportunity to our reviewers. You know, all the positive cultures from the blood and other stereo body sites will go back to the review system of the reviewer. And then in that case, the ID reviewer can look at the, you know, already approved decision again, you know, based on the positive cultural result, and then give a second recommendation to these antibiotic use. And this give the AM give a chance of promoting the escalation for the antibiotic use for inpatients. I'm now showing you the review interface between the ID physician and the antibiotic prescription for the inpatients. You can see here, here is the list of individual patient information, and also on the right-hand side, you can see the yellow color labeled blood culture indicates that these patients had a positive blood culture. So the ID reviewer will realize that, of course realize that these patients had a positive blood culture, and they required a second review for their current antibiotic use in this patient. And this is so along with the antibiotic prescription, the prescriber have to provide the reason for the antibiotic choose. For example, in this patient, the reason for the antibiotic prescription is a suspected bloodstream infection, and then we can, from this system, the reviewer can check the vital signs of this patient, including temperature, body pressure, blood pressure, and also we can review all the laboratory testing of the patient, hematology, biochemistry, and also microbiology. We can also see the chart records of the patient, and we can, of course, review in details the microbiology survey results. And the current medication list is also shown in the system, and we can check the image study results from the PEC system. Of course, we can see the change of the vitals of the patient. So in altogether, with all the information available, we can make a decision on our recommendation to the antibiotic prescription for the inpatient. So this is pretty much a system called patient-centered review system. And we make an ID reviewer make a decision based on all the information necessary on our desktop. And in recent years, as I mentioned earlier, we try to make the best use of digital device to improve our AMS execution. And we recently, actually during the COVID-19 pandemic, we set up many business intelligence dashboards that can show the real-time, almost real-time data to our to all the physicians, including the reviewers. And in this way, we can, with these BI dashboards, we can facilitate, we can streamline our AMS execution. With this dashboard, actually, the dashboard actually can help to trace, in terms of AMS, the dashboard can help to trace antibiotic consumption in OPD, in ER, and also in the wards of the hospital. And also the BI dashboards provide opportunity for the clinical pharmacist to guide, antibiotic use for VRE bacteremia in ICU patients. And actually we launched such program with the implementation of the BI dashboard in the ICU setting in our hospital, and we as a result, such program actually improved the correct choice and dosage for the treatment of VRE bacteremia in our ICU patients. And certainly, the such BI dashboards in the ICU can provide the prescribers the so-called prescriber-driven timeouts for the antibiotic use. This is kind of so-called self antimicrobial stewardship. And from this figure, you can see that the dashboard system can help to trace OPD outpatient antibiotic use trend nearly real time. I think they can with this in this dashboard, BI dashboard, they actually update the information about antibiotic use about almost daily. And the BI dashboard can help to trace antibiotic use trend in the ER, and also, of course, can help to trace the antibiotic use in the hospital patients almost in a real-time manner. Pictures shows you the BI dashboard can help us to implement a clinical pharmacist-driven program, that improve the precision therapy for VRE bacteremia in ICU patients. As you can see that the correct dose of the daptomycin use for VRE bacteremia in ICU patients has been improved with the implementation of this program. And also the implementation of the BI dashboard in ICU provide an opportunity for the antibiotic prescribers in the ICU for antibiotic timeouts. This is what we call self-stewardship. This means that the prescribers actually can see how much antibiotic used and how long the duration of antibiotic use for the critical patient they care, and they can have an idea when they should stop antibiotics based on the clinical response and also the microbiology survey results for this patient. And finally, I'm going to show you with the following several slides how we did with during the pandemic with in the antimicrobial stewardship in Chang'an Memorial Hospital. The background of this figure actually reflects the level of lockdown in the community during the pandemic. As you can see from this figure, with the increasing level of lockdown in Taiwan, actually the defined daily dose per 1,000 patient days antibiotic use actually increased with the level of the lockdown. But after the lockdown, is lifted, the antibiotic use, the DID of the antibiotic use actually reduced to a level similar to the antibiotic use level in the normal days. Again, if we will specifically look at the DOT of antibiotic use, you can see the DOT actually increased over time with the level of the lockdown during the pandemic. But after the high peak of the epidemic in the community, you can see the DOT of antibiotic use actually returned to the regular level. I mean, compared to the level of antibiotic use in previous months. Also, if we specifically look at hospital-acquired infection density, the density usually increased along with the increased level of lockdown in the during the epidemic in the community. But soon after the lockdown, reduced in the level, so the HAI infection density actually returned to a normal level. So all the results suggest that our AMS system during the lockdown period and during the COVID epidemic period actually is functioning. And we successfully control the antibody use during the pandemic. And when we specifically look at the antibiotic disapproval rate during the pandemic, what we found is that the disapproval rate actually did not change, too much, along with the variation of the lockdown level, suggesting that our the functioning, our AMS system functioning at a relatively quite stationary level. So again, I still have to stress that the main three strategies against the spread of resistant bacteria are: firstly, we should have a surveillance system for the antimicrobial resistant bacteria. We have to implement strong infection control program to prevent HAI in the hospital setting. And finally, AMS is an indispensable part in what we call the triangle system to defend the spread of, to contain the spread of the MDR organisms in the hospital. With this, I stop my presentation. So we work together to fight against not only COVID-19, but also the silent pandemic of AMR. Thank you for your attention.